confirm whether or not they have a set of symptoms and a history that's consistent with the diagnosis of Parkinson's disease. Because as you can see in the patient I described, many of her treatments themselves caused her psychiatric symptoms. When she was placed on dopamine agonists, she shortly developed auditory and visual hallucinations, as well as hypomania for treatment of her depression, as well as for her Parkinson's disease. All of these medications can cause psychiatric symptoms, although patients can develop them in their own right as well. So we first look at the symptoms that are necessary for the diagnosis of Parkinson's disease, the symptoms and signs. And what you expect to see is bradykinesia and at least one of the following: rigidity, rest tremor potentially, and postural instability. We also look for other of the UK brain-blind criteria, in which 3 or more are required for a definite diagnosis of Parkinson's disease. Parkinson's disease begins unilaterally and progresses asymmetrically. Again, you may see a rest tremor, but not every patient will experience a rest tremor. They may have a postural or an action tremor, and about 30% of patients won't have any tremor whatsoever. The disorder should be progressive, so over the time, you should expect to see more symptoms, and as I stated, persistent asymmetry, which affects the side of onset greater than the contralateral side. In general, once a patient is started on levodopa, you should see an excellent response to that treatment. Over time, patients will develop levodopa-induced chorea, although if a patient hasn't been on the levodopa for that long, they may not have this side effect. Individuals should have a levodopa response for 5 years or more, and ultimately a clinical course of 10 years or more. Signs suggestive of a non-Parkinson's disease diagnosis include early postural instability, the absence of a rest tremor, although that is not exclusive, early dementia beginning within the first few years of the diagnosis or of onset of motor symptoms, a rapid progression of motor symptoms, early or severe dysautonomia, and the involvement of other neurological systems. Those are important to look for because you want to make sure that you're treating a patient for psychiatric complications of Parkinson's disease and not for another neurodegenerative disorder such as progressive supranuclear palsy, cortical basal degeneration, multiple system atrophy, and so forth. The traditional view of Parkinson's disease is that the disease begins with the death of the substantia nigra dopamine cells, and over time, once those degenerate to a certain point with, say, for example, up to 80% of those neurons lost, you will begin to see the onset of motor symptoms. But early in the course, you don't really need symptomatic treatment, but over time, patients need to have those motor symptoms better controlled, and the Parkinson's medications do help. Over time, however, individuals develop motor complications, such as dyskinesias or on-off fluctuations, where the medicines just don't have a sustained benefit between the dosing interval. And then what was typically thought was that at the end of the diagnosis, as the disease was progressing, 10, 15 years down the road, individuals will begin to experience cognitive decline. But that really is not so much the case as we look at individuals even very early on in the disease. But again, our traditional view of Parkinson's is focused on the loss of dopamine neurons, the pathognomonic changes being the loss of dopamine neurons, the substantia nigra, which prevent transmission to the corpus striatum of dopamine and precludes smooth coordinated movements. We also see the presence of Lewy bodies in the substantia nigra over on the right-hand side of the slide, with the little bodies within the nerve cells that are staining bright pink. However, the neuropathology of Parkinson's is not just affecting the nigrostriatal dopamine system, it affects multiple dopaminergic systems, and this is probably why it affects other aspects of mental functioning, and why we have neuropsychiatric complications in addition to motor dysfunction. So in addition to the mesostriatal system, there's also the mesolimbic system and the mesocortical dopaminergic systems. And what we have affected are corticostriatal thalamic circuits that affect motor functioning, as well as reinforcement of learning and our higher order processing. Slide. And then it's important to understand that the neuropathology of Parkinson's is not just affecting dopamine, but it is affecting other neurotransmitter systems. We have neuronal loss in the locus coeruleus, causing loss of norepinephrine, in the midbrain raphe, with loss of serotonin neurons, and the nucleus basalis affecting acetylcholine, all involved in mood regulation as well as in memory. Lewy bodies are not just restricted to the substantia nigra, but the Lewy bodies are present in the limbic system as well as in the cortex. And then at least half the patients with Parkinson's will show Alzheimer-type neuropathological changes. They may not show evidence for definitive Alzheimer's disease, but they do have evidence for Alzheimer-type changes that may feed into why there is a cognitive loss. So when we look at Parkinson's disease, it's not just a motor disorder, but there's now what is described as the PD non-motor symptom complex. And we have the neuropsychiatric symptoms that I will be discussing today, but also autonomic symptoms, sleep disorders, and a number of other symptoms, sensory symptoms, pain, paresthesias, olfactory changes, fatigue, seborrhea, blurred vision, diplopia. Again, Parkinson's really being more of a systemic disorder than a disorder just restricted to the motor system. Treatment options in Parkinson's disease for the motor symptoms themselves are also important to understand. The gold standard is levodopa, which is combined with carbidopa to enable the levodopa to cross the blood-brain barrier and to become available to the neurons in the central nervous system. Dopamine agonists, the most commonly used now being pramipexole and ropinirole, the MAOB inhibitors, misagiline, selegiline, other medications, anticholinergics, as well as amantadine, and non-pharmacologic treatments, in particular exercise, which is extremely important for all patients with Parkinson's disease, but the deep brain stimulation and palidotomy being the neurosurgical treatments that are used. So with that background, now I'll be speaking more specifically about the various psychiatric disturbances. And it's important to recognize that patients are often evaluated first for their symptoms as well as for the actual disorders that they have. And what you see in patients with Parkinson's disease, just in this inventory that was done in the Netherlands, in Norway, among rural Norwegians, that about 60% of patients had at least one psychiatric symptom, with the most common symptom being depression in the yellow bar. 38% of patients being affected by depression, and about almost 30% of patients having hallucinations, another 20% having anxiety. But if you go on down the list, apathy, agitation, delusions, irritability, disinhibition, even euphoria, every symptom in this neuropsychiatric inventory being recorded in at least one patient in this survey. Interestingly, we see about the same proportion of patients being affected when we look at psychiatric diagnoses. And this is data from our longitudinal sample that's being followed at Johns Hopkins as part of our Parkinson's Disease Research Center. This is an earlier sample of 117 patients. And what you see here is about, again, that same 60-40 ratio. These are patients from the Baltimore, Washington metropolitan area. Again, similar to in Norway, however, where 60% of patients have at least one symptom, here we have at least about 60% of patients with at least one psychiatric diagnosis, with the majority being affected by depressive disorders and anxiety being the next most common diagnosis. Now, it's important to remember that in this slide, a number of patients will have more than one diagnosis. But we were reporting here the most problematic diagnosis. And even among the 40% who aren't affected, a number of those patients are actually treated to remission. So they weren't symptomatic at the time that they were seen. So they had a treated depressive disorder. So the 60-40 ratio is pretty useful to remember in terms of at least one out of every two patients with Parkinson's